Good evening, everyone. Welcome to tonight's webinar. This is a part one of a two-part series of webinars called Demystifying Dementia. This event is an event in collaboration. It's a collaboration between COORDINARE, Capital Health Network, who run the ACT and Southern New South Wales Health Pathways Programme, Illawarra Shoalhaven Health Pathways Programme, and Dementia Training Australia. My name is Jill O'Donnell. I'm the ACT and Southern New South Wales Health Pathways Manager, and I'll be introducing our speakers tonight shortly. First of all, I'd like to acknowledge the traditional custodians of the lands where we meet on tonight. I'm currently on Ngunnawal country. I know we're spread across the region this evening, across a broad area, geographical area. I'd like to pay my respects to elders, past, present, and emerging, and acknowledge and welcome any Aboriginal and Torres Strait Islander people here tonight. So before we begin, I'd just like you to ensure you have your full name in your profile, on your Zoom profile, so that your name can be recorded for CPD reporting if you're a GP. The session is being recorded, but your cameras are off throughout the session. If you have any questions, can you please use the Q&A function, and our speakers tonight will pick up these questions and talk through them as we go through. And also after tonight's session, you'll receive an online evaluation form to fill in. Please complete this and take the time to give us some feedback about how your future learning needs, as well as how you felt the session was tonight. And you'll get a certificate of attendance that will come through as a result of you filling in your evaluation form. So that'll be great. And GPs will be registered for CBT and RACGP CPD points. So our next session is on the session 2 of this series is on the 20th of March coming up as well. So as you may know, our PHNs have been working on the Department of Health and Aged Care funding Dementia Support Pathways Programme. This initiative has the intended outcomes, including a primary care workforce with improved dementia knowledge, who feel more supported in diagnosing and/or referring people for diagnosis and ongoing support, more timely diagnosis, and increased referrals to both diagnostic services and to post-diagnostic supports and services. Consumers that receive earlier diagnosis and access to supports and services that they need, and improve dementia awareness in the community, and for the person, family, and the carers to feel more supported and have better quality of life during the dementia journey. And you can see the learning outcomes on there tonight. This webinar is, as I said, part 1 of 2, and that will offer a practical and stepwise approach to improving your knowledge, skills, and confidence in recognizing, diagnosing, and managing dementia in the practice setting. And it's very exciting tonight to have 2 very experienced speakers from Dementia Training Australia to present. I'm sure it'll be a really informative evening tonight. Just a quick reminder about Health Pathways. So Health Pathways provides evidence-based point of care information to general practitioners and other health professionals. It's peer-reviewed, localized information, which is designed for use at point of care. They're written and maintained by a team that includes local GPs in our areas, and we work closely with the GPLUs and subject matter experts to ensure pathways are relevant and to our health environments across this region. And there are multiple health pathways that relate to dementia. You can just see the list there. There's a whole lot of pathways that relate, both clinical pathways and request and referral pathways for dementia. So this is highly relevant to our people tonight. So I'd like to introduce our speakers. First of all, both speakers will work together tonight on this presentation. Dr. Karen Savery is a Brisbane GP who works in clinical practice, residential aged care, and medical education. She's passionate about the education and mentoring of GPs, particularly in the area of aged care and dementia. Karen has worked with Dementia Training Australia to increase GPs' confidence and recognition of and in the management of dementia. So welcome, Karen. And Dr. Rebecca Moore. Rebecca graduated from the University of Adelaide She has a varied career, and initially as an aviation medical officer in the RAAF. She has since worked in general practice and urgent care in the UK and Australia, and is now working as a GP in Newcastle. She has a special interest in aged care, and in 2022 she worked as an advanced trainee in geriatrics and is currently completing a Masters of Dementia through the University of Tasmania. She's also an educator with Dementia Training Australia. So I'm just going to pass across to our speakers tonight.
Thanks, Jill. Welcome, everyone. Let me just share my screen. Okay, so we would also like to just acknowledge the traditional owners of the lands on which we're all sitting. I'm sitting in Turrbal and Jagera country at the moment, and just pay our respects to elders past, present and emerging, and extend that respect to anyone in the room tonight who is Aboriginal or Torres Strait Islander person. So as Jill said, these are our learning objectives for tonight. And it is a two-part session, so mostly tonight we are concentrating on diagnosing dementia. Our second part is going to be on the management of dementia. So we're more than happy to answer questions along the way using that Q&A panel. If your questions are around management though, we encourage you to come to the next one on the 20th of March and ask your questions at that point. But we are going to look at how do we diagnose dementia tonight. What we really want you to take away is that dementia is more than just a memory problem, that really our cognitive assessment tools are not diagnostic, they assist us, but they're not a diagnosis in itself, and that quite often GPs are actually well placed to make a diagnosis and then our management as well in the next one. But before we really start, we really do want to think about language. So we know, more than 20 years ago when I started in general practice, it was very common to hear people referred to as demented, a wanderer, a screamer, really language that was not particularly respectful. And certainly over the last few years, there's really been a move, particularly by people who are living with dementia, to have language that is more respectful, that's accurate, and in time is actually reducing the stigma of having dementia itself. So we sometimes still get it wrong, but we encourage you to think about the language that you're using when you're talking about somebody who lives with dementia. And if you're wanting to find out more, Dementia Training Australia does have some good resources on the actual language guidelines. And that link is there, which will be sent to you. So we're talking about dementia. We know that dementia is progressive. It is going to get worse over time, and it is a global, meaning a whole brain condition. It is also across the world, so we could consider it in that way too, but it's global, it affects the whole brain, and it's life limiting. We know that a diagnosis of dementia is actually a life limiting diagnosis and really involves that generalized brain degeneration. But because it's across the brain, it does affect different people in different ways, and there's certainly a number of different types of dementia. If we look at dementia in Australia, we can see that the most common type of dementia is actually Alzheimer's dementia, closely followed next by vascular dementia, and often there is a mix between the two, but because particularly Alzheimer's is the most common one that you're going to see, that's where we're really going to focus our attention over the next two webinars. After vascular, the next most common we will see in Australia is Lewy body dementia, and that's really important to be aware of because of the significant side effects that occur if we're using antipsychotic medication in that particular type of dementia. And Lewy body dementia is certainly characterised by those visual hallucinations, so that's one really to look out for. The frontotemporal dementia, a couple of percent in Australia. Again, that's a little bit different again. It might present with some personality changes or some language changes. So we want you to be aware that they're there, but we're really going to be concentrating on Alzheimer's. There's, of course, other types of dementia that you might have come across in practice, such as that related to alcohol or Parkinson's. There's certainly a lot more about our trauma related dementias in the news at the moment. If you lived in Africa or a different country in the world, you might see a lot more HIV related dementias. So we know that that's really an umbrella term that we're using to encompass a whole group of different conditions, but all of them do have that progressive nature, which continues to impair function. So that's really where we're looking tonight, though, is specifically concentrating on Alzheimer's dementia. So Beck, I might throw it to you. Why is dementia important to know about?
Well, firstly, dementia is very common. So we know that in Australia, there are about 400,000 people living with dementia currently. And unfortunately, because of the increase in population, it's predicted that in 25 years, that number will double. So probably about 800,000 people will be living with dementia, which means that we are going to be seeing a lot, and it's very important, I think, that we feel comfortable and confident diagnosing and managing it. So as you can see, dementia increases with age. So from the ages of 65 to 75, something 3% are affected, then 75 to 85, 10%, and over 85, we're looking at about 30% of the population will be living with dementia. Having said that, dementia is not a normal part of aging. For those of you who work a lot in residential aged care facilities, you would know that probably over 50% of the residents are likely to be living with some form of dementia. Notably, in our Aboriginal and Torres Strait Islander population, the rate of dementia is increased 3 to 5-fold, and it does tend to come on earlier as well. One thing that surprises some people is that dementia is the leading cause of death in women in Australia, and is the second leading cause of death overall. It's also the leading cause of disability in, I believe, the over 65s. So in essence, it is essentially very important that as clinicians, we feel comfortable and confident with dementia, because it's a big issue, and it's going to become an even bigger issue. So why do we talk about dementia? I think, as we've mentioned, dementia is common. I think historically we haven't really learnt much about dementia in our training. During my medical school, I barely remember learning anything about dementia. And I think there's also generally a lack of health literacy, not only in the general population, but also in among the health professionals. And so I think one consequence of that is that it's underdiagnosed. And it's not well understood. People will often attribute some of these cognitive changes to normal aging, for example. The other thing about dementia is that certainly it has a profound impact on the person living with dementia, but it does also have a profound impact on those who are in their immediate environs, and also sort of the ripple effect, such that dementia affects a lot of people. And then from a national point of view, there are economic and considerations as well. So, I mean, the other thing to note is, and we'll talk about this in management further, but, we believe that about 40% of dementia may be attributable to modifiable risk. And so even if as GPs we're able to reduce the number of people who develop dementia, even by a few percent, that would have quite profound impacts moving forward. And then finally, dementia is a terminal illness, as we'll discuss later, because of the impact of the pathology on the brain. Ultimately, it will cause physical changes, and it does ultimately end in death. So, and this is a bit more about, why is it that we're underdiagnosing? And I think it's both partly due to the general understanding of what dementia is in the population. There is, as we've said, quite a profound stigma, unfortunately, still that is associated with dementia. And I think some people are reluctant to come to the doctor to talk about their concerns. Either they're embarrassed or often quite frightened about what it's going to mean. People perhaps will put down signs and symptoms down to normal aging, which indeed is not the case. And then I think as clinicians, it's also hard because in some areas it feels a bit unclear as to how you can make a definite diagnosis. There's not one definite test that you can do that says, oh, yes, this is definitely dementia. And in the past, there's certainly been that nihilism, the idea that, well, what can we do anyway? What's the point? But certainly we know now that making an early diagnosis can be very beneficial. And there are actually a lot of things that we can do to help on the journey, both for the person living with dementia and for their family as well. So this is, in a nutshell, the benefits of making an early diagnosis. So it helps the person in front of you, it helps their family, and it helps you as the clinician. And if you think about it, there are lots of ways that it can be helpful. Obviously, getting an earlier diagnosis means that the person is able to really make some plans for the future, to prioritise what it is that they want to achieve, to work on their strengths, and to start to also work on areas that might be useful as their condition progresses. And again, this is something that we'll talk about more in management. The other obvious thing is that we want to be able to make decisions for the future, which will involve the person living with dementia, and doing that early means that that person has more of a say in how things progress. And, we would like to get these decisions made while they still have capacity. I think in my experience, often having been able to have the chat to the person, it really alleviates a lot of guilt in the family. I think those families where it's all happened a bit later on down the track and they never really got the chance to talk to their loved one will often feel guilty about making decisions, for example, about putting them sort of in an aged care facility, for example. And also it does help as a clinician knowing that a person has a diagnosis of dementia. And I mean, I think it's really important, say, some of our nursing home residents, for example, and it's fairly evident that there has been a change in cognition. And often these are people that perhaps you wouldn't really bother about making a diagnosis. But I certainly do think that it is valuable. It can be very helpful both for the staff and for the family in understanding some of the behaviours and management. I know fairly recently we've had a lady and it was a little bit unclear quite what was going on, because in terms of her recall and her memory, she seemed to be managing quite well, but some of her personality, there had been quite a clear change, and she was being quite rude and fairly blunt and quite fixated on certain things. And so when we did a bit of a deeper dive, it became very evident that she was struggling on several cognitive domains. And actually, by being able to provide a diagnosis of dementia, it allowed the staff to be a little bit more understanding of things, and as a clinician perhaps a little bit more patient, because she did have a tendency to repeat some of the information, etc. So I do think it's also quite helpful there. All right, Karen, can you fill us in on how we actually go about making a diagnosis, please?
I can. So this is our first framework that we're going to give you to help you in making a diagnosis, and then we're going to unpack how we actually do that. But what we're looking for in the end is these 4 things. So we want to see a gradual onset of that cognitive decline. So if you were completely fine last weekend and you're not now, then we're not going to call that dementia at this point. You might be somebody at risk, but again, we want to see that gradual onset of that cognitive decline. We want to see it progressing, because that's, by our definition earlier, one of the things that we do see with dementia is a progression of that cognitive decline. The third thing is it's got to interfere with your function. So really, and that can be very individual, which we'll talk about how we tease some of that out, but it's got to, that cognitive decline's got to interfere with your function, and it can't be due to any other reason. So that's our 4 things that we need, and that's really the DSM-5 distilled down to the absolute basics for us to help us when we have someone sitting in front of us. As far as those rule out criteria or the exclusion criteria, we know that in the presence of these things, we don't want to be making a diagnosis of dementia. It might be, though, that we need to come back and keep reassessing a person's cognition, because they could have a diagnosis as well as one of these things. But until we treat these 4 different exclusion criteria as best we can, we don't want to be making a diagnosis. So we know that delirium can affect cognition, and that's a much more acute, it's not that gradual onset progressive decline that we're looking for, but that acute change in cognition, it certainly is a red flag for us that there might be a reduced cognitive reserve, and the person may be at risk of dementia or has dementia. But in the presence of delirium, we want to be able to reassess down the track. And usually we'd suggest waiting at least 3 months, maybe even up to 6 months after somebody has had a significant episode of delirium to reassess. So if you're getting a discharge summary back from the hospital that somebody's been in with delirium, make sure you make a note in your practice software just to reassess their cognition again down the track, because they're certainly going to be at risk because of that reduced cognitive reserve. In the presence of alcohol and other drugs, we know that cognition can be impaired. Now, this may be drugs that we've prescribed, and we're certainly going to talk about some of those in the next session. But if you had somebody who was on a lot of opioids or some of our antidepressant medications or a mix of things, that may be enough to cause some cognitive impairment. Certainly if you're under the influence of illicit drugs or alcohol, that is also may well impair your cognition. So we want to be able to reassess when somebody is not under the influence of some of those things. We know mental health disorders can be tricky. So if somebody's got a very profound depression, they actually may look like somebody, that pseudo dementia where you're getting significant cognitive impairment alongside of that. And in fact, that may be one of our sort of presenting ways somebody might present with dementia. So it is something that, again, if somebody has significant anxiety, significant depression, other untreated mental health disorders, we want to be able to treat those as best we can and then keep watching cognition. If they do have an underlying dementia, we know that that's going to keep progressing over time. So it is something that's going to continue to worsen. And our other organic disorders really come into some of the investigations that you'll already be doing. So looking for things like hypothyroidism or space occupying lesions or hypercalcemia, so low B12. So some of those organic disorders that, again, we want to treat as best we can and then reassess. And if there's some very difficult intermixing of some of these exclusion criteria, that's when you may actually be seeking a referral or another opinion from a geriatrician or a psychogeriatrician, if it is difficult to tease out. But for others, we want to be able to treat them. A lady I saw who had a TSH of 88, certainly her cognition significantly improved when we treated that. So we've got our gradual onset, getting worse cognition, affecting function, and none of these other things that might be impacting. We'll just see, there is a question about dementia diagnosis can result in a dismissal of the patient's legitimate concerns and questions or dismission of behaviour change. So we do know that some of that will come into our management as well, but you are allowed to have a dementia diagnosis and have some, significant pain that might cause some changes in behaviour or other mental health conditions. And we certainly will talk about some of how dementia itself can also affect that mental health realm. So we'll talk about that in a moment. So if we can hold that question for a little bit further. So that's our first framework, and we're going to come back to that framework, but really thinking about those things that we're looking for, the things that we want to exclude. Our next framework is really looking at the domains that dementia affects. So thinking particularly about Alzheimer's dementia, as we said, because that's the most common one that you're all going to see, but we know that dementia affects a number of different domains, and this 5 things can give us a structure to our history taking, the things that we're looking for, as well as when we come to our next session, when we look at management, can help give us some structure to management as well by thinking about the areas that dementia affect. But we did say that cognition is one thing, that we're looking for that gradual onset of cognitive decline that's progressive. So I might throw to you, Beck, just to talk us through what do we mean by cognition? We've said it's not just memory. So what are we looking at?
Well, there are lots of different areas of the brain which obviously have different cognitive functions. And it's quite interesting. I think dementia is one of those, I think one of the reasons it is so interesting is depending on the type of pathology and depending on the location of the pathology, you are going to get different cognitive changes. We know in Alzheimer's dementia that about 85% of Alzheimer's dementia will present with some form of short-term memory loss. And this is largely because the pathology of Alzheimer's disease starts in the hippocampus, which is part of the brain that's involved in sort of forming and placing down new memories. So it's really important to ask about memory, and in particular short-term memory. Things that you might notice would be loss of short-term recall. In the clinic, people might have missed appointments, people might have missed scripts. I also ask about whether they've lost things recently. Some people report going into a room and then can't remember why they are in there, or going to the shops and then actually can't remember what they needed to get from the shops, or indeed buying double of everything because they had forgotten they'd already bought those groceries earlier. So short-term memory is very important when you're taking a history, and definitely is very important in an Alzheimer's diagnosis. So we have a little mnemonic here called REALMS, which is quite a neat way of thinking of the different types of cognition. So executive function is more pertaining to the frontal lobe. So thinking about planning, about organisation. This is where judgment will sit as well. So at this point, it's worth sort of taking into account any safety considerations. That mental flexibility that, if you've made a mistake and somebody corrects you, the ability to take those corrections into account, and also insight. And I'm sure some of you have experienced the difficulties that you can have in a person who is developing some cognitive changes but lacking in insight into those cognitive changes. Attention is that ability to both focus on one thing or to multitask. It's also to do with the processing speed as well. So you might hear, a partner saying, we've watched this telly program several times before, but they can't remember having seen it. Or I like to ask about, if a person's been reading a book, do they remember where they've left off, or do they have to flick back a few pages to get the gist of the story? And in terms of L for language, that expression says a lot to say a little, is also worth bearing in mind as well. So the idea of somebody can really talk quite a lot, but the conversation and the content is quite empty. It's always a bit of a red flag too. Other things in language is people will often themselves notice some difficulty in word finding, or they might talk around a word, that thing I put my head on when I go to sleep at night, being the pillow, for example. Sometimes naming objects and recognizing objects as well. In the mini mental assessment, you ask what is a pen and what is a watch, but I'll often pick up a stapler, and that seems to be, I don't know if you've had that experience, Karen, but one of those ones, and they do the actions, they know what it is, but they can't quite come up with the word. And then also just sort of smaller errors in syntax and grammar, it's worth just being aware of as well. So the M stands for motor, or the praxis, and so we're looking here for any evidence of any dyspraxia. So in particular, coordination or understanding how things work. For example, if a person has been having difficulty using their phone or using the television remote, or how to switch the air conditioning on, etc. And later down the track, you may have experienced where, for example, a person's given a knife and fork or a power plug, and not quite sure what to do with it. And then social really pertains to behavioural changes, as we mentioned, sort of changes in personality, perhaps some inappropriateness in conversation, and those sorts of more behavioural changes, particularly in the frontotemporal types of dementia that you can see. Do you want to tell us a little bit about the other domains then, Karen? I think the next one was function, wasn't it?
That's correct. So we know that again was part of our inclusion criteria, was that change in function. And we certainly see as cognition declines that function tends to decline as well. It can be very individualized, so it may be, some standard things that you might commonly see, like people not being able to use their remotes or not being able to work out their banking anymore. But it also might be that sort of individualized function as well. So I had a fellow who used to do lots of cooking, and suddenly he couldn't follow a recipe anymore. Another fellow who used to go cycling, use his GPS all the time, now can't work out how to use the GPS. If he gets lost, he can't work out how to use his phone to get back home again. The accountant that can't use a spreadsheet. So certainly some of those functional things can be quite individual. And again, as GPs and practices, often we know our patients well. So, my patient that used to cook 70 Christmas puddings every year, who suddenly again couldn't work out how to do it, couldn't remember the recipe she used to use despite having done it for the last 30 plus years. That was a real change. So really looking for those changes in function. So if you're always somebody that can't work out how to use your password or your phone, that's not going to be a good way of assessing if your function's changing. But if you're somebody that's come from sending emails all the time and now you can't work out how to read or send an email, then that's a concern. So some of that function is quite individualized. Obviously, it can affect things as in our picture, things like shopping, using medication, remembering to take things, driving certainly is an important one that we'll come back to in our second session. But all of those sort of different areas of function certainly can be affected as cognition starts declining. Looking at our next one, so that sort of psychiatric symptoms, we know that again it can be quite common to have that bit of anxiety around the time of diagnosis, often because you're just not sure of what's going on. So people always feel that bit uncertain, and that's where the diagnosis, although it might not be one that they wish for necessarily, actually helps explain what's going on. So that anxiety is quite common. Certainly, as we said, people can present with depression or develop a depression on the way through after diagnosis. We certainly do see hallucinations and delusions. In up to 50% of people with Alzheimer's dementia, we will see some of those delusions or hallucinations. So certainly worth asking about, looking out for. And we need to be aware of some of those in our carers as well. But certainly that psychiatric or mental health domain is one that we certainly want to be aware of the impacts that dementia can have in that. Behaviour changes often we think about towards the end of dementia. When we've seen people who, because of that difficulty in communication, might be unable to communicate needs, so might call out or might wander, or might be agitated. But we do see some of those behaviour changes early as well. So again, often we can see some of that irritability. People might withdraw from some of their hobbies or things that they do, possibly because they're just not following conversations or following, bridge or whatever their hobby might have been. But that sort of withdrawal, social sort of withdrawal, irritability, lack of motivation, all of that certainly can be part of the dementia process as well. And finally, our physical decline, again, we're often thinking about that as dementia becomes more advanced, where we do see people becoming bed-bound or chair-bound, becoming less mobile, having difficulty with swallowing, being sort of independent for all the ADLs. But there is some work being done in the earlier stages of dementia, looking at changes in stride length and some of the other things that possibly we might be able to use down the track as part of our diagnosis as well. Somebody's asking about the link to the second session. I'm sure that will be put up at the end, but you can note it down. It's the 20th of March. And then we're definitely going to be looking at management in that section. So if we overlay those 5 domains onto a graph, what we see is, a graphical representation of that function and cognition really declining along the same time, and physical as well. Mental health things can occur at any stage along the journey, and that behavioural change, although there is some early on, tends to be more as we progress. Now, we call it stage 1, 2, and 3 because mild, moderate, severe, nobody really thinks that their early diagnosis of dementia being mild is mild. So we're calling it stage 1. So stage 1 is really when somebody is usually still at home, starting to have some difficulty, but still reasonably independent with what they're doing. By stage 2, as cognition and function are declining, those care needs are going up. So often it's around this time that people are needing more significant assistance from family, friends or carers, or looking at moving into residential aged care. By stage 3, that's really when people are fully independent for all their ADLs, bed-bound, chair-bound, losing mobility, losing that ability to swallow, and that physical decline that really happens at that stage. So when we look at that, we can see that in stage 1, that's really that time we want to be looking out and looking to make a diagnosis where we can. Because we've got time then, as Beck said earlier, to think about some of that future planning, to look at priorities for now, really looking at quality of life, keeping people as independent as possible for as long as we can. Often what happens is around that stage 2, messy, everything's overlapping, is often when a diagnosis is made, and it might be the person's had a fall and had a broken bone, or ended up with pneumonia and is in hospital, or had a spouse or carer who's suddenly not there anymore, and it's suddenly their functional difficulties are really apparent. that's much trickier for the person living with dementia and their carers if we're making a diagnosis in that very messy stage. So it is something that, again, we're hoping as we go through this that we're really trying to shift some of that diagnosis to being a bit earlier if we can, and as early as we can. You might notice though that there is a box before stage 1 and that cognition and function isn't starting from 0 or starting from the top in stage 1. So I might get you to talk about that, Beck. What is that box?
So it's now become a lot more evident that there is a sort of condition, particularly in Alzheimer's dementia, that sort of predates the real change in function. So we know to make a diagnosis of dementia, there has to be a significant change in normal daily function. But people who are experiencing cognitive changes, objective cognitive changes, so changes either on the cognitive assessment tools or certainly with a good collateral history, but are still managing to maintain their fairly normal daily function, albeit perhaps using some compensatory sort of mechanisms, they would be given a diagnosis of mild cognitive impairment. Now, I suppose one of the reasons why we're focusing on this a lot more is that we know that for a cohort of people with mild cognitive impairment, they probably, well, they are harbouring some Alzheimer's disease pathology. And because there are some new medications that are currently in trial phase, but showing that it is possible to potentially change the pathology, and some very modest evidence suggesting that that will mean change in cognition. If we can get people a diagnosis of mild cognitive impairment, so very early, then it may be that we're able to actually change their trajectory. Now, not all mild cognitive impairment does go on to develop into a dementia. So essentially about 10 to 15% of people who are diagnosed with mild cognitive impairment will go on each year to develop a dementia. But that means that at about 5 years, about 50% of people won't have a dementia. And in fact, some people will have reverted pretty much back to sort of normal cognition, and some people will have plateaued. So it depends a little bit, well, it depends on what the underlying cause of the mild cognitive impairment is. If the underlying cause of the MCI is probably Alzheimer's pathology, then it is highly likely that over time it will develop into a dementia, which explains the slide that we just showed. But other sorts of mild cognitive impairment might be caused by some of those other things that we discussed, you know, the change in the thyroid function or medication or grief, you know, and so it may be that they will actually revert back to normal. So if we have a look again at that trajectory, I think that you can see here that you do start to get some cognitive changes prior to stage 1. And you do also start to get some functional changes, but they're the sort of ones that people tend to be able to compensate for a while.
So
does that make sense?
A question in the chat, Beck. Can you describe the elements to look for in mild cognitive impairment and what strategies might they be using? Certainly some people that I have use a lot of lists, and we all use lists, but they really rely on their list to be able to actually function. But anything else you want to add to that?
Yeah, and I think a bit more of a reliance on partners and that sort of thing. It's a little bit... It's a little bit of a controversial area, really, at what point you say somebody is not functioning normally. So I think there is in the literature a bit of discussion as to whether, for example, you know, difficulty in finances is sufficient to make you a stage 1 dementia instead of a mild cognitive impairment. But you might notice that people are either, you know, relying more heavily on family members to do things, or, perhaps not doing them as much. I had a gentleman who used to do all of the travel arrangements for these quite elaborate holidays. And, it had become evident that, he was having some difficulty following the timetables and that sort of thing. So he just wasn't doing them as much. He was still able to do them, but not as much. But it wasn't sufficient to say that his function had grossly changed. But that was a good example, I would say, of a mild cognitive impairment.
And I think it's often that increase in sort of word finding difficulties compared to peers, or, they notice compared to a peer, just not, memory's just not quite as good, or there's just those, certainly word finding is something that I see quite a bit, but actually still functioning completely fine. So I've got a lady that really struggles with some of her words, but she is in her 80s, she uses her computer, she sends emails, she fixes the TV, so functionally, she's independent with all her ADLs, but she does have those word finding difficulties if you're talking to her, and she's had that for at least 5 years now. So I think she certainly is in that mild cognitive impairment.
Yeah, and another gentleman, he just felt that the number of careless errors that he was making in his typing, for example, had increased, and his wife sort of agreed with him that had actually been the case. But again, it was fairly minor but objective change. Yeah.
So at this stage, our biggest difference is function. So if we think back to our inclusion criteria for dementia, we're looking for gradual onset, getting worse, cognitive decline with effect on function. So that's a big thing that makes a difference between it being mild or MCI versus stage 1 dementia. So if we're thinking about that sort of diagnosis, at this stage, in another 5 or 10 years, we might be telling you something quite different. But at this stage, like many other conditions, we know that the diagnosis is still mostly based on our history. So it's really that opportunity to sit with a person, and ideally some collateral as well, but 80% really comes from history. Our examination and investigations is more looking for those rule out things. So looking to make sure there's nothing else that might be causing that cognitive or functional impairment. But I just want you to think about for a moment, how might this look in practice? We know that we certainly can get people coming in concerned about their memory, and often I've found in my practice that they are often people with either mild cognitive impairment or more likely with anxiety or mood concerns. Often people who have stage 1 dementia don't always realise that there is any issues, but it might be the person who raises a concern. It certainly might be concern raised from family members or carers. But I want you to think, who else in your practice could actually notice some of this happening? And since we're not using the chat box, we won't get you to answer it, but it's worth, if you haven't already, but certainly talking to your practice nurses. So practice nurses are often very aware of who has got some cognitive decline because they're spending time doing wound checks, certainly, health assessments, care plans, where we're actually spending a bit more time with someone, and they might be finding that repetitive conversation or forgetting words. So having a chat to your practice nurse about if they've got any concerns with any of your particular patients coming in for their over 75 health assessments or wound checks. We know your reception staff also may actually be aware of it if they know to let you know. Certainly know in our practice there's been times where the reception staff know that somebody's going to miss an appointment, so they ring them just to make sure they come, or they're rung multiple times to check when the appointment is. So again, having some discussion with your reception staff to find out, are there any of your patients that they have concerns about, or who ring them multiple times or forget when their appointments are, is really valuable. And the other one is just new doctors or even our GP registrars. So sometimes that fresh eyes, we get to sort of see people over a very long period of time, often in general practice, and kind of get used to the way they are. But sometimes that fresh eyes looking in at someone going, hang on, you know, they didn't quite answer questions in the way we expect, or there's a few things here that I'm concerned about. You know, again, worth talking to your registrars if you have them within your practice. But somebody else who's mentioned bilingual patients who lose a language, and absolutely, I've certainly had that happen where English is the last language to be gained and often the first language to be lost. So that certainly is another clue. One thing we do talk about at times is a head turning sign. So if you have a patient who's come in with a family member or a carer and you ask them a question and they immediately turn their head before answering to get the answer from the person who's come with them, just keep in mind that that might be just a sign that they're having some difficulties with their cognition. So we know we see it in teenagers, but if we see that in a person who is older, who doesn't normally come with a family member, then that head turning sign is again something that you can keep a lookout for. And obviously all of our practice software, we can keep an eye on if people are forgetting, you know, should have come in earlier for medication, and that sort of thing. Anything else you want to add to that, Beck?
I've worked in a regional area for a long time and have quite a good relationship with some of the pharmacists. And I actually, you know, will often talk to the pharmacists and they'll say, oh, so-and-so's, you know, been having some difficulty understanding things or has missed their Webster packs or not taken, you know, everything that they need to. Or they'll also do the home medication reviews and actually go to the house. And so, you know, certainly I find the pharmacists can be really helpful. And I also think, I remember a geriatrician saying to me, if a person presents to the geriatrician appointment on their own on time, that's always a very healthy sign. So you know, I think certainly whenever a family member comes with their relative, you know, I think that in itself is sometimes a bit of a red flag.
So if your person hasn't noticed anything specifically, you can use some of these different conversation starters just to broach the subject. It is something that actually might take a bit of time. As Beck said already, often insight is, you know, a part of cognition that is impaired, but certainly in that stage one, some people are very aware that their memory is not quite what it was, or that other people are worried. So really being able to kind of just have that conversation in a, you know, respectful, destigmatized kind of way, but just being able to be confident to bring it up if family members, staff members, community members are worried about a person's cognition. But it certainly might take a few visits. So we had those 5 domains. So as part of those 5 things, that's all the things that you might be looking out for as you're taking history, particularly those first 2, but certainly seeing, are we noticing anything else with mood, with behaviour, or with perhaps some physical decline as well.
I've certainly mistaken dementia for anxiety a couple of times actually, in that sort of you know, people coming in, they're quite anxious, they're worried about things, and we've taken a route down looking at the anxiety, but actually it was early symptoms of a dementia.
Yeah. And I think certainly just that being uncertain all the time often makes people anxious. If they're very anxious, that's also going to affect their cognition. So sometimes it is difficult to tease out, and sometimes we do need assistance with that. So if we just go back to our inclusion criteria, because we're about to actually give it a go on a case. So gradual onset, getting worse, cognition, definitely interfering with function, and it's not due to anything else. So that's really what we're looking for. So that's all of those different domains in a nutshell of what we're looking for to make a diagnosis of dementia, and ruling out those other things that can affect cognition but actually are treatable causes of cognitive impairment. Might still have dementia, but we need to rule those things out first. So, keeping those things in your mind, we're going to meet Anna. So Anna is 75. She lives alone. She normally comes on her own, and this time she's coming with her daughter Sophie to get her flu shot. She's pretty healthy for 75. And I know you said a moment ago, Beck, that if someone comes with a family member, that might be a red flag for you. Wondering what might be going on.
That's right.
So let's watch the video, and I want you to think about are there any evidence of her cognitive decline that might be getting worse, and thinking about those domains as well. So what are we noticing in this video?
Hello.
Hi, it's good to see you.
Yeah.
How's things been going?
Look, I've come about the flu injection. I think I'm a bit late, am I?
You are a little bit late, actually.
Oh.
Yeah, I was wondering, we sent out some reminders. I thought maybe you didn't get the reminder for the flu.
I can't remember getting one, no.
Yeah, well, that's great that you've come along today.
Yeah.
I haven't seen you for a little while. How have things been going?
Cutting back a little bit. You know, my garden was fairly big, and I'm just sort of downsizing a bit on that, because although I still love it, it was getting a bit much for me, so I'm cutting back on that.
And I just had a look through your file before you came in and noticed that your blood pressure medication were due a little while ago. Have you still been taking your tablets for blood pressure?
I think so.
Yeah, you take them in the evenings, Mum.
Oh, do I?
Yeah.
Right, yes, okay. But I've run out, have I?
Well, the prescription looks like you should have run out a little while ago if you'd been taking them regularly.
Oh, right. Perhaps I miss some sometimes. I'm not sure.
Well, it can be hard to remember, and there are things that we can talk about that might make that easier for you.
Right, okay.
Was there anything else that you were concerned about at this stage?
Well, we just had a little bit of a worry with the memory loss, like forgetting to take the pills, which we've just heard now. There's been a few incidences of leaving the stove on overnight, not realising that you'd turned the stove on.
I don't remember that.
No, I know, and that's the thing. There's been a couple of things that that you don't remember. Yeah. I don't know if that's normal at this stage, at age, but I just thought it might be worth a check
on some of those things.
Yeah.
In a moment, I'll take you around to see our nurse, and she can give you the flu needle, because that's the main reason why you've come today.
Yes.
Yeah.
And I'll ask Jane to also check your blood pressure and weight, like usual, just to make sure that everything's going along okay.
Right.
One of the other things I'd like to ask Jane to do with you while you're there is to do a real simple memory test to make an assessment about how your memory's going.
Yes.
Because it seems like, from what Sophie and you were saying, that you've been having a little bit of difficulty with your memory.
Yeah, I'm not sure about that, but maybe have the test.
It would be good, and you've always been very proactive in your health and want to keep on top of things, so that's part of that process of staying on top of things, if that's okay with you.
Yes.
Yeah?
Yep.
And then perhaps as part of that process of trying to keep on top of things, while you're out with Jane, would it be all right with you if Sophie and I had a conversation about what she's been noticing for you with regards to
that's
your health?
fine. That's fine. Yeah.
Yeah, happy with that?
Yes, I'm quite happy with that.
So just thinking about that, what did you notice? I'm just going to pause it. I hope it won't play again. What did you notice? So did we see some evidence of some cognitive decline? So some memory issues? Do we see some evidence of some functional decline if we're thinking about leaving the stove on, cutting back on a garden? There's certainly some things that should make us a bit concerned, maybe not taking her medicine, like she was unaware of the memory lapses. There was a bit of a head turning sign in the middle there. There's certainly some evidence of cognitive decline, isn't there? And that functional decline as well. I think the one thing, if I was giving feedback to our Dr. George, is I probably wouldn't say a simple memory test. I think the minute you say test, that makes people anxious, and for some people it's not simple. So I just say some memory questions often, or just some questions. Really take out that stigma of what the test might actually be. But he certainly, I think, very respectfully got some of that information out. Hopefully you noticed he was still keeping Anna very patient-centered. You know, he was still keeping her as the focus. He was looking at her, directing his questions at her, and I think it is something that we do need to be aware of when we have somebody with cognitive decline, that we do keep them as part of the conversation and not just referring it purely to the person that's answering all the questions. So I think he certainly was very respectful in that side of things. And I've certainly used his line about being proactive about your health. I think that was a very respectful way to kind of ask about collateral history and ask about doing some of those memory things. Anything else you want to add to that, Beck? Otherwise, I'm going to...
I think I agree with everything you said.
Excellent. I'm going to throw over to you as why collateral might be useful. Hang on, before we do though, we did have someone ask, can the head turning response also be a soft indicator of possible elder abuse? Possibly. It's certainly one to always keep in mind with anyone that has some cognitive decline anyway. But it certainly tends, the patients that I've had, it's very definitely related to that cognitive decline and memory, where even my young patient that I have that's 52 head turns to his wife all the time whenever we ask him a question. So it certainly is a very definite sign of cognitive decline, but obviously we've always got to keep in the back of our mind, could there be something else going on? There's another question before we move on. In female patients, is it less likely that short-term memory loss is an early sign of cognitive impairment? Certainly around menopause, we often see that sort of brain fog, word finding kind of descriptions, and that often improves over time. But I don't know if you want to add anything more to that, Beck.
A few things. So certainly short-term memory loss is, as I said, more common in Alzheimer's disease, and Alzheimer's disease is more common in female patients. I think we haven't really touched on it, but there is also a condition called subjective cognitive impairment, which is different in the sense that the person is experiencing those things, but there's no objective evidence of them. So people feel like they can't remember, or they feel like they're having difficulties finding words, but actually it's not shown objectively on any of our assessment tools or in the collateral history. And yeah, I think it may be that I'm not sure if that's more frequent in females or not, but that in itself can be a little bit of a red flag too.
Certainly worth checking out. So I'll throw this to you, Beck.
Well, yes, and you probably noticed that Dr. George asked Anna if it would be all right for him to talk to Sophie, and that's a really important part of doing the collateral history, just checking with the person that they're happy for for you to talk to one of their family members about what's been going on. And ideally, it's most helpful if you can take the collateral history separately. Sometimes people feel a little bit self-conscious or worried that they're going to offend the person. So if you can do it separately, some people seem quite all right with it. So I think you assess it a little bit on a case-by-case basis. You can often get very interesting information from family, and this is something that we would do a lot in the hospital. You'd get consent from the person, and then you'd call the family member, and you'd get a much, much better understanding as to sort of the background of things and what has been going on. So whilst it's not absolutely essential, it's certainly very helpful and important if you can get a collateral history. And very much you touch on those cognitive domains that we've talked about already. So cognition, function, any change in their mental health, hallucinations, delusions, sort of sense of paranoia, for example, or sometimes there are concerns about people taking their money or having an affair and that sort of thing, which can often be gained through the collateral history, as well as any changes in personality and behaviour. And then also it gives you an opportunity to create a bit of a rapport with the family member, because often they're having a pretty difficult time, or they're worried, or they're stressed, or they just don't know what to do. And so I think it's a really good opportunity to, in a way, to also look after them and make sure that they're able to get the help that they need as well.
So we're going to have a look at Dr. George taking that collateral from Anna's daughter. And again, just thinking about what other information have we garnered around those 5 domains.
So it's great that you could come today, and
Yeah.
I really appreciate you being here, because it helps to make my job so much easier. It sounds to me like you're noticing a bit of a change with your mum. So if we think back to perhaps how she was a year or so ago, what would be some of the things that perhaps are different between now and then?
She was certainly a lot more active a year ago. She was doing a lot more around the house, doing a lot more in the garden, going out to her bridge a couple of times a week with her friends. She doesn't do that as much. She sort of is getting more fearful of leaving the house, I think. Maybe it is that she's just feeling more frail, I don't know. But she is doing things like turning the stove on and not realising that she's done it and leaving it on overnight. As she mentioned about her gardening, like she actually abandoned half of her garden, which was quite an unusual thing for her. So, you know, the medication, I didn't know that she wasn't taking her...
blood pressure.
Yeah, for the medication. So there's a few things, and I think she's generally okay, but there's just a few things that I'm concerned about, because, you know, some days I come in and she hasn't even dressed, you know, whereas she's always been very meticulous about, you know, looking good, and she wouldn't leave the house not dressed, you know. So it's out of character. That's my main concern, is that she used to be very busy, and now she sort of slowly seems to be withdrawing, but she's denying that. Okay, so she's saying that she's okay, but...
So you're seeing one thing and she's saying something else?
Yeah.
Yeah. Which, it's a common thing. It does happen a lot at this stage. In your mind, what do you think maybe might be going on for your mum?
Well, I mean,
I
think, you know, she's 75, she's not that old. But, you know, I know that old people sort of start to lose their memory a bit and sort of slow down. You know, it could be that there's something going on in her body that's slowing her down a bit, or, you know, I'm sort of more concerned about her, you know, mind, because she's been very sharp all her life, very on the ball. She'll be completely on the ball, and then she'll completely forget the conversation that we had the day before. So it's out of character, and it's been going on for a little while. It's taken me a bit to get her here to see you. So
had the thought of dementia entered your mind, that might be something that's going on for your mum?
Do you think these are the signs of dementia? These are potential?
Potentially, and that certainly would be one of the things in my mind that we would need to look into, and that's why I've asked the nurse to do the memory test, because that helps in terms of gathering some information about whether that is the cause. Certainly, I agree we need to look at other medical causes, any other kind of physical causes, have a look at medications, make sure that there's nothing in a medication, although I think just with the blood pressure tablet it's unlikely that would be the cause of what's going on. And then we'll together work out get a sense of a picture of what's happening, and then together work out a plan of where to move forward.
No, I really appreciate that, George. Thanks.
So as we can see, that extra collateral certainly added some more information, didn't it, around those domains. We certainly had a bit more evidence around her cognitive decline, and the way that he asks, as far as referring back, how was she a year ago, how was someone 2 years ago, really gives you that point in time reference. Is quite a useful way to be able to compare how somebody is managing now compared to a point in time. We certainly got some more evidence around that functional decline, didn't we, between dressing, a garden, the stove, medications. We got some more information about the psychiatric domain, around her being a bit more anxious, and becoming sort of more withdrawn. We certainly got some more information, possibly even about that sort of behaviour and physical domain as well. So really looking at some of those changes about withdrawing from her hobbies, not being able to perhaps manage her garden. That might have been a physical thing. She might have had difficulty actually getting dressed, which may have been part of it. I know I had a patient recently that was really struggling to work out. She would come trying to put her underpants on her head, and she was really confused with how to actually do the dressing part by herself. So very rich information to add to what happens. Somebody's asked about elements of paranoia. Very tricky. So we do know that from an insight and paranoia, sometimes we just can't get permission for that collateral. You don't get that same information that you might get otherwise. It doesn't stop a family member giving you their concerns though, and I've certainly had one recently who I didn't have permission to talk to them, but the family member actually emailed me with all their concerns. So I can look at that, I just can't ask them anything further. So it is something that we don't always get that collateral, but where we can have it, it certainly can add quite a bit. So we've had our sort of 80% history from the person, possibly some collateral as well. Then we're looking at that sort of physical examination. I'll pass this over to you, Beck.
Sure. So in the physical examination, a lot of what we're trying to do firstly is to exclude those other causes. So we're trying to exclude a delirium. So certainly making sure that the observations and the vitals are all within the normal realms, excluding infection and inflammation, etc. Other causes of change in cognition would include things like stroke. And so that's where doing a fairly focused neurological examination can also be really helpful. One thing I think is very important is to make sure you check weight. Weight can give us quite a lot of information. So if there's been a significant change in weight, that will often reflect the fact that somebody's not eating as much, or potentially there have been changes in their mood, and certainly warrants further investigation, but is yet another red flag. Looking at vascular risk factors, so certainly, as we know, significant proportion of dementia is vascular, so checking blood pressure, doing a cardiac examination is also very important. And I think also looking for other sensory impairments, so making sure that their vision is as it should be, checking hearing, because, a person who's having difficulty with their hearing and difficulty with their vision is going to struggle managing some activities of daily living and also performing the cognitive assessment tools that we're using as well. Here we are. Hello. So in terms of cognitive assessment tools, there are several, and I think our recommendation really is to find maybe 2 or 3 that you're comfortable with and, practice them, because you'll get to really understand the nuance of the answers. Some people are fortunate to have practice nurses who are able to administer them, but most of them are relatively short, and actually you often will get some good information if you're the one that's actually administering them. So the mini mental state examination is probably the most commonly used because that's embedded in most of our software. I suppose you do need to be mindful, particularly for people who have a fairly high cognitive reserve, those people who are quite well educated. They can often perform very well on the mini mental state examination, even if there are some significant cognitive changes. Like personally, I find that the mocha is probably more useful, particularly for discerning those more you're not quite sure. The mocha has got a little bit more testing in some of the other domains, a bit more information about visuospatial, more naming of objects, a bit more on language and fluency as well. So I think the mocha probably gives you a little bit more information. The GP cog you can get online, and that has also been shown to be helpful at discerning some of those more those that are a little bit more unsure. But that's a very short and easy test, which involves a recall component, and it also involves the clock drawing task, much as the mocha does. And I think, Karen, you'd agree that the clock drawing task is often quite interesting. People often find that is quite a struggle.
Ruda's using her watch to kind of cheat on the clock drawing the other day and still got it wrong. So I'm like, oh.
Yeah, that's right. You know, and I had a gentleman quite recently, and he had to put the hands at 20:08. He just couldn't work out where the 20 was, and it was quite a surprise to me because it was actually, it came a bit out of left field, but it was again a red flag. Rudas can be really helpful, and I would encourage you to have a look at that one. It's very helpful for people who have English as a second language, or for people who have a lower educational level, because it's based more on sort of everyday experiences. You get a shopping list, you have to remember the shopping list, and there are some things about, what would you do if you're in a busy road and you need to cross. So all of these cognitive assessment tools do come with essentially a manual or an instruction guide as to how to use them. But I think we would recommend that you just get to be very comfortable with a couple of them. There is the kicker, and there are 3 different forms of the kicker, and that has specifically validated for people of Aboriginal and Torres Strait Islander heritage. There's a remote and urban and a Torres Strait Island variation of that too. I don't know, which ones do you tend to use, Karen?
I flick between a couple of them. I do like the GP mini cog, which is again validated for use in general practice in Australia, which is just short-term memory and the clock face. But if I'm assessing somebody, my aged care patients, I actually prefer the Rudas because it's a bit more conversational and less like a test. And I'll certainly use mini mental as well. I've used the mock on a couple of my highly intelligent patients, but I think as I've always used the mini mental, I just tend to go with that one as a pretty standard one that I use. But you will notice that in our inclusion criteria, there was not a cognitive assessment number of anything. So it is something that we know, sometimes it will help in our diagnosis, but you can have a normal mini mental state and actually have dementia, which I had a 52-year-old fellow who was still scoring in the normal range, but had some significant decline compared to where he had been, with some functional decline, which was certainly dementia. You could also have an assessment tool that scored very poorly because of some of those exclusion criteria under the influence of medications, drugs, other organic sort of causes. So it's something that helps us, but it's not absolutely essential in making our diagnosis.
I think that's a really good point, Karen, because sometimes too, people will do very well, but you're really sure that something's not right.
Like 80% is history.
Yeah, and I think you know, even if you can't put your finger on it, if you've got that sense that, oh, I'm not happy with this, you know, I think that is sufficient to, you know, refer for further testing. And I suppose it depends what's available in your area, but certainly, for example, for those younger people, you know, a neuropsych assessment might be very beneficial.
So in the interest of time, I'm going to just move us on to investigations, which we really spoke about as being looking at our exclusion criteria. So ruling out things that may affect cognition, like our B12, like hypothyroidism, like our high calcium. CT brain, again, when we're thinking about ruling out structural causes, actually is enough. So we certainly do get asked at times, do we have to do an MRI? But actually a CT for this purpose is what we're ruling out space occupying lesions, chronic subdurals, that sort of thing. A CT is going to give us enough information and is relatively easily accessed compared to some of our other things. Depending on your population, and certainly in another 20 or so years' time with the syphilis outbreak we have currently, syphilis would definitely be one that we need to have back on the list of, doing more regularly. So the other ones are there to consider depending on the patient in front of you. Now, if we look at Anna's results, so she's certainly from a history, we had evidence of cognitive decline and functional changes. When the nurse did her MMSE, she scored less than 24, so she got 22 out of 30. She certainly had those significant functional changes, and her physical exam and her investigations were all normal, so none of those exclusion criteria. So again, just want you to think about how confident would you be in making a diagnosis that this is dementia. So she's got gradual onset of worsening cognition, it's getting worse over time, functional changes, and no other reason for it. So she's meeting our 4 inclusion criteria with no exclusion criteria. So it is the stay tuned for session 2, because what we're going to be looking at next time is what we do from here when we make that diagnosis, or we think we're pretty sure that's what the diagnosis is. So just in recapping, we hopefully from this first session, you've taken away that dementia is more than just about memory issues, that really our cognitive assessment tools are exactly that. They help us with an assessment, but they're not diagnostic, and that actually we can do quite a fair bit to be able to diagnose dementia. So really looking at that history and excluding other things. If you're interested in looking a bit more into some of what's available on Dementia Training Australia website, there's heaps of different resources within that. And we've also got the Dementia in Practice podcast, which is made by GPs and for GPs. And there's some really good deeper dives into some of the challenges around dementia from that side of things. I'm just going to answer a question in the chat. Yes,
Sorry.
I did answer that already, but the people in the videos were actors. So Hilton Copy is a GP based in New South Wales, and the lady in question was actually an actor from the Rosehaven. So all actors, so consent has definitely been given. And yes, people do die from dementia. So another question is the chat, is that actually reasonable to have on a death certificate? So we know in that stage 3, as the brain continues to become more affected, swallowing, breathing, all of those functions that are essential for life become impacted. So yes, people definitely die from dementia. So that is not unreasonable to have on a death certificate. And I know we have 5 minutes left for, just let me stop sharing, for health pathways. And then if we have time, we can finish the final question. So Jill.
Thank you. Thanks to both of you, Rebecca and Karen. I'm just going to try and find out how to reshare my screen now. Can you see my screen now?
Yes, we can.
Right. Thank you very much. That was really informative, and I learned a lot from that as well. And it's the 80% history is quite interesting as well, because there's a lot of talk about sending people off for diagnostic testing, but there's so much involved in the history. So that was really interesting. So thank you both. I'm sure everyone's learned a lot from that session. It was very interesting indeed. I've put the login path. I'm sorry. On the next slide, I've put in the login pathway, the logins for both health pathways programs, for those that aren't aware of that. Obviously, there's two different, they're generic pathways. There's a generic passwords that we use for the two health pathways programs across the region, and we'll send out details of that as well after the sessions. For those that contact your PHNs if you're looking for any more information, and obviously you can see on the PHN websites as well. There's a lot of information on there. As part of the Dementia Pathways program, both COORDINARE and Capital Health Network have mapped the local dementia services available to people in the region. And so this is just the link. This is just the details of the one that's for COORDINARE. And likewise, the second one here is a resource. These are both designed to be patient facing, and one of these is for carer facing, and one of is patient facing for people on their dementia journey. So those are really useful information resources, and they're on your actual PHN website. And you can get hard copies available for us if you want them actually for your patients. So the other thing, as far as health pathways is concerned, as I say, we've got lots of dementia pathways, and it would be good to have a look at those especially after tonight's webinar. And if you have any feedback you want to provide, on every health pathways page is a send feedback button, which means you can give any feedback to us to make sure that we keep the pathways up to date if you think there's anything that should be changed. And the other thing is we rely heavily on SME engagement, so your expertise is important. So anyone who actually has a strong interest in health pathways, in dementia, we'll be very happy to hear your feedback on the pathways. So just to say thank you very much to everyone for attending tonight. Thank you very much to Karen and Rebecca for your wonderful talk. And we will have an evaluation form that will come out, but we'll also send you all out a link to the next dementia event, which is on Wednesday, the 20th of March. It's also on your website pages, on the PHN website pages under the events tab there. So we'll hopefully see everyone again there next time around. And as I said, once you have your evaluation form filled in, you'll get CPD points, and that'll be coming out in the next day, in the next 24 hours. So thank you very much again for everyone attending, and thanks very much for our speakers. It's been a great night.
Thank you.